mental health aspect of losing what you love is profound.
If you have to pick, it's a lot better to choose a disease or disorder that isn't rare. Pick something like diabetes, that everybody has, because you go to the doctor and they go, oh yeah, diabetes, I know what to do. We'll measure your blood sugar. We've
found that my cardiac MRI is scheduled for April 20th, 2027.
It's everywhere now. So basically I'm palliative and you can't save me anymore.
This is happening to nurses. They're more and more getting therapy, and they're coming. They've got anxiety disorders, PTSD, because they
just utter confusion in the medical system. This
2012, right up to 2025, has been FOIPed and looking at the stats. They knew what was happening. The NDP were in for 4 years.
What those students are going into right now is horrific.
Beg Prime Minister Mark Carney to send the Canadian military in and set up some tents like during COVID.
It's been pure chaos, endless change, and a lot from nurses, physicians, everybody in the system, that it's never been less focused ever. As an example, the Edmonton zone, the last hospital they had was built in 1988, and stop the chaos.
This is a politically centered podcast.
Hello, ladies and gentlemen. My name is Jeremy Silver, and this is a politically centered podcast. The following podcast is a 3-part journey through the Alberta healthcare system that started with a friend of mine. His name's Kim Johnston. Now, if you're from southeastern Alberta, or for that matter, lately Western Canada, because he recently had a radio show that spanned across a good quarter of the country, Kim Johnston is a name that you'll be familiar with. He's been the voice behind thousands of radio mornings, sporting events. He's been the voice of so many events in the community and charity functions that I've lost count over the years how many things he's been part of. He's given to his community, and in return, he got caught in the middle of what some people consider the collapse of the Alberta healthcare system. Our first interview is with my friend Kim Johnston. Our second interview, we were very thankful to have Dr. Andrew Wilner, a neurologist from the United States of America, currently practicing in Nashville, Tennessee. He came on the show and spoke with Kim Johnston after the first interview was recorded. We also had Ali Morrison on that podcast, who's an advocate within the Alberta healthcare system. Ali Morrison, whose list of credentials are very impressive, has been actively petitioning the Alberta government and the United Conservative Party of Alberta to, at the very least, admit that there's a problem. She brought with her 2 guests who, like Kim Johnston, have suffered within the Alberta healthcare system and struggled to even see a doctor. Some of the stories are shocking. Some of them have extremely, extremely sad outcomes. At the very least, you'll get a picture of what many people in this province are going through right now. Our third interview is with Dr. Paul Parks. Dr. Paul Parks is an emergency room physician who is also working out of Medicine Hat Regional Hospital and has been an advocate within the healthcare system. Dr. Parks and Ali combined have been 2 of the loudest voices in the province of Alberta, and we are beyond thankful they could come on this podcast. If you want to skip ahead to any part of this podcast, I'll be posting timestamps on the screen shortly after you see this intro. I would highly encourage you to watch all 3 episodes, especially the last one, because by no stretch of the imagination is Dr. Paul Parks last in his importance. If you've ever been sick, if you've ever had to dial 911, if you've ever had a loved one that has been in crisis, it is worth watching the following podcast, because the next phone call to 911 could be you. We're grateful that he's here with us today, and it's very difficult for Kim to speak, even though this is what you've done for a living for how many years now, Kim?
This is my 34th year of radio in Western Canada. And over the past year, and especially over the past 3 months, it's just become very challenging navigating through this condition and through the healthcare system, which has been extremely challenging working through that. So, I guess an unexpected healthcare commentator And I have learned a lot about the system, that's for sure.
Yeah, I mean, I know that, like, I don't know whether these changes that are being made are going to be for the better or for worse, but there is a transition period. And I guess everybody accepted that there was going to be some people falling through the cracks, but I don't find it acceptable, even though we knew it was going to happen.
Yeah. Well, my understanding, and you excuse my struggling through this, it is an apparent case of trigeminal neuralgia. What I have been confirmed to have is an arachnoid cyst at the base of my brain. An arachnoid cyst is something that actually you're born with. Many people have them; they're very common. However, rarely do they expand or turn into anything that might affect your health. So what might cause an arachnoid cyst to expand is normally trauma, some kind of trauma. And I've never been in a car accident. I've never bumped my head that I can think of. And the only thing that comes to my mind was back in 2015. I'm the announcer for the Medicine College Rattlers volleyball team. And during warm-up, I remember getting hit in the head by a volleyball spike really hard. And I remember thinking at that time, I wonder if that did some damage. I wonder if something happened there. But went on with everything, with my life. It was a few months later that I really started noticing some changes to my enunciation. Words were coming out different. There was a bit of a slurriness in my vocal tone, and it was concerning. And so at that point, I talked to my doctor, got referred to neurology in Calgary, and after a very quick 10-minute assessment, they said, everything seems fine. Whatever the problem is, it seems insignificant, undetectable. But I knew something was wrong, unmistakable. And at that point, I went to a couple of local orthodontists. And they said, well, you do have a little bit of a stronger jaw, a bit of an underbite, they say. You need to get that fixed. That surely is the cause. And so I put my career on hold and double jaw surgery, a number of surgeries, basically full facial reconstruction from the nose down.
I remember that. That was how many years ago was that now?
6, 7 years ago now.
Yeah, I remember you told me sorry, my dog in the background likes joining the interviews. But I remember you had told me that they had to actually break your jaw multiple times, didn't they?
Oh yeah, yep. It's a hell of a process. But to continue to provide for my family and the career that I love, it seemed like an investment in my future. So I did, and got through it. And within a few months, these symptoms returned and accelerated. So that was misdiagnosis number 2. The first one being neurology, saying that no problem is detectable, and major jaw reconstruction was the next one.
So, well, Kim, sorry to interrupt. So I actually thought that this was a completely separate issue and that maybe it was something that happened during the surgery on your jaw, but you're telling me this is literally a continuation from 7 years ago? Or
I feel 9, yeah.
9.
I feel that this is a 9-year massive hole that I've fallen into in our healthcare system. massively.
I remember at one point you were doing your radio show when you were KJ and
Yep.
Kirby, and you were
Embracing,
holding your jaw like this so
Yep.
that you could talk.
Yep. And that was due to deteriorating muscle control. So the symptoms from there continued, very scary, very just slowly losing your ability, your coordination, everything. Many doctor's visits, many theories. A year and a half ago, I was told that it has characteristics of Parkinson's. So oromandibular dystonia is kind of under the greater umbrella of Parkinson's, from my understanding, a movement disorder. But my condition continued to deteriorate. And what they were telling me still didn't make a lot of sense. And earlier this year, to my neurology team, I said, look, you have a patient that is struggling to talk, is now struggling to eat because my muscle coordination in my face, left side, is completely not there now.
Putting aside the fact that you talk for a living.
Yep.
Right.
And given all of that, I said, surely a brain MRI is warranted. After all these years of struggling to talk, a brain MRI seems to be a pretty basic piece of information that might be quite telling. The neurologist said, okay, I'll give you that. That does make sense. And so after a 9-month wait for that MRI, the symptoms continued to progress. I had the MRI, and the first finding was a cyst in the Meckel's cave area of the base of the brain. So that is an area where the trigeminal nerve passes, and just a lot of very intricate nerve fibers in that area. And there was a cyst with mass effect displacing the trigeminal nerve, which controls function, sensation, everything in this part of the body, everything. Even as implications to things like tear ducts and just a lot of your facial functions. And from there, the neurology team said that this seems like an interesting finding and may explain all these symptoms that I've been experiencing for nearly a decade. Not once in those 9 years of speech problems, eating issues, jaw function, was a brain MRI even thought of. So now the diagnosis, the MRI, the radiologist report also indicated that significant muscle atrophy in the left side, which in medical terms is called denervation. It's when a muscle doesn't get the nerve stimulation, it shrinks. And so that has thrown off my bite dynamics. And so basically what is happening is I'm now in a situation where neurology, oromaxillofacial surgery, mental health supports now, we've got a number of different factions of healthcare that need to come together for the fix. It could have been a much simpler thing years ago, but now we're in this 5-alarm fire, so to speak. And our current healthcare system is so fragmented. You have all these disciplines that don't communicate with each other. And plus the added component of being in rural Alberta, which is a huge part of the problem when healthcare facilities, even in the third largest city in Alberta, even in Lethbridge, are completely unprepared for any kind of somewhat challenging medical diagnosis.
Kim, wow, I just you've had such an incredible journey. I've known you that almost the entire time, and I still had no idea some of the things you have been through.
Yeah.
How has you've spent almost half of your life building your career, becoming one of the better known voices on radio, that I've lost count the amount of people over the last 10 hours who have said, I grew up with Kim. I grew up listening to Kim. Kim, KJ and Kirby in the morning. It was so great listening to Kim. And how has stepping back, because you've just had to recently step back from that, how's that affecting you?
Profound. Yep. It's the mental health aspect of losing what you love is profound. The fear of a murky diagnosis, many doctors looking at you and your condition saying, I see it and I see the suffering, but I don't know. Good luck. Good luck.
That's got to be devastating.
I've had one doctor ask if perhaps MAID is an option, which seems completely ludicrous, just given the fact that my diagnosis is still not firmly entrenched. It seems to me just unconscionable that MAID is part of the conversation before a complete, big picture of the condition is even known. So yeah, to answer your question, a very big impact on me and on my family.
It must be. I don't want to ask if you're experiencing depression, but it's got to be situational depression at the very least. Like how are you coming to terms with all of this?
Yeah, the mental health aspect of it is part of the bigger picture now. You've known me for some time now.
I have.
Friendly, easygoing, laid back,
yes,
helpful. It's kind of all the things that I've always taken a lot of pride in. In terms of the mental health, ahead of most doctor appointments these days, you get a questionnaire, right? You get the little clipboard and they ask, your mental state and just screening questions like that. Every single time I have, honestly, Jeremy, I've checked that box for mental health, struggling. I've probably done that questionnaire in different medical offices a dozen times or more. Definitely more. Not once has the conversation been initiated, though, right? Do they read the questionnaire? It doesn't seem like it. We hear so much, we talk so much about men's health and men's mental health. We have got so far to go, as I've learned, because very, very little or no emphasis seems to me, from my experience, to be put into addressing the mental health issues of chronic illness.
You know, Kim, you really are an incredible person. I cannot imagine the pain and suffering you're going through right now, and you are still not just advocating for yourself, you're advocating for other people. And all the times you and your mom have volunteered at the Christmas dinner that I run every year, the United Way Spirit of Christmas Feast, all the times you have gone out of your way to help people on your own time in this community, including me. I just checked the GoFundMe and it's up to almost $1,600. I launched it last night. You did not ask me to do this. You did not ask for any of this. As a matter of fact, you asked me not to say anything a year ago, and I sat on it for a really long time until you finally broke your silence. And it was I'm so thankful that I can do this for you. At the very least, I think there's enough here to get you a plane ticket and a hotel somewhere where maybe the medical system can diagnose you properly and get you some help. Your community loves you. I've never seen in all the time I've been doing these the amount of support pour in this quickly for anything that I've done. Your community has been sending me messages, and it's just very, very heartwarming. What do you want to say to everybody? Because yeah.
It, I, I wholeheartedly and I genuinely appreciate it. I, I am not going to lobby for donations. I'm not going to be posting it on my page. I don't. It's uncomfortable for me to ask for help. And the thing is, healthcare wise, we all have something. We all have our thing, right? Healthcare wise, we all have our thing that is currently bothering us or will be coming. If you don't have your thing right now, your healthcare thing, you will. It's coming.
Yes.
And this is mine. And I have to face it bravely and with determination. And it's, you know what? It's not the end of the world, right? For me, it's affecting here. It's affecting mental health. It's affecting my family. But, I have a friend that just lost his leg to diabetes. It seems to me that if this is my only problem, I still have a lot to be thankful for, right? The rest of my motor skills are fine. I can walk fine. I can move. I have most of my energy still, right? So in many ways, I'm very thankful. I'm thankful to those that contributed more than I can even say. But I am determined to get through this, and I'm determined to continue to help others in any way that I can as well. And thanks to you as well, Jeremy.
Kim, it's the least I can do. I know you've never done anything for me or anybody else and expected things in return, but you showed love to your community, and your community is loving you back, and it's our turn. So I'm going to keep running the GoFundMe, and I know you have not, again, you have not asked for a single donation, and you're not going to ask, but I'm asking for you, and I'm not okay with just sitting here watching you suffer. I'm sorry. I just can't do it. So, you're a good man and you deserve better than this. So that being said, thank you for coming on and struggling through this. I know how hard it was for you.
Thank you, brother.
You take care of yourself. All right.
Thanks, everyone.
This is part 2 of a 3-part series we've put together around Kim Johnston's health journey and the broader issues it highlights within the Alberta healthcare system. Before we go any further, it's important to add some context. Over the past several years, Alberta's healthcare system has undergone significant restructuring, including policy changes under Premier Daniel Smith that expanded the role of private and contracted healthcare delivery alongside the public system. Supporters argue these changes are meant to reduce backlogs and improve access, while critics warn they risk straining an already overburdened system and diverting resources away from frontline public care. These debates are an important backdrop to stories you'll hear throughout this series. Before I get into today's conversation, I do want to make sure you check out part 3 of this series as well. Part 3 will be airing directly after this interview and was recorded immediately following Kim Johnston's first interview featuring Dr. Paul Parks. He's an emergency room physician at Medicine Hat Regional Hospital who's been on the front lines of Alberta healthcare since the crisis began. It's one of the most important conversations in this series and provides firsthand insight from the front lines in the emergency room. If you've watched part 1, you already know who my friend Kim Johnston is and his story. Since that first interview, Kim has been admitted to Red Deer Hospital and is now receiving care within the Alberta healthcare system, so hopefully he's got some good updates for us today. Today's conversation brings in 2 additional voices to help add some context and perspective. Joining me today is Dr. Andrew Wilner. He's a US-based board-certified neurologist and a professor of neurology at the University of Tennessee Health Science Center. He's been practicing for decades and is a widely published medical writer who's spoken publicly for years on neurological health. Earlier in his career, he trained at the Montreal Neurological Institute, where he completed both his neurology residency and epilepsy fellowship. He also has direct experience with the Canadian healthcare system. He's here today to speak generally about neurological conditions like the one affecting Kim Johnston, including what symptoms shouldn't be ignored and how delays in treatment can affect outcomes. He's not here as Kim's physician, but to help us understand the medical realities behind situations like this. We're also joined today by Ali Morrison, whose list of credentials is a mile long. I was very impressed, Ali. Ali is a classical musician who has lived, worked, taught, and performed in more than 10 countries. She moved to Canada 8 years ago and now lives in Cochrane, Alberta, where she teaches piano to children. Beyond music, Ali has spent decades working with children in conflict and crisis zones, including Guatemala and Peru, using music as a tool to teach and reach children who had become nonverbal after experiencing extreme violence. In recent years, Ali has become deeply involved in Alberta's healthcare and EMS crisis. She has documented paramedic experiences, worked with journalists gathering FOIP records, and helped bring those stories directly to the Legislative Assembly. Her focus is now on documenting the real cost of human healthcare failures in Alberta, making sure the people affected are named, acknowledged, and not forgotten. We're going to begin today with Dr. Andrew Wilner. Doctor, you've had the opportunity to watch Kim's interview that I sent you, and you saw his follow-up on Facebook. Kim, I had copied your post and sent it to him. Though, how many times have you seen things like this? What can you add to this?
So my understanding is that, first of all, thanks for inviting me to join your podcast. We hadn't met before, and so it's a privilege for me. And also, it echoes back to my days in Canada. I've been back once or twice, but I had a pretty intense 4 years there. It was a lot of fun.
Did you at least pick up some French?
Oh, yes.
Oh,
in
good.
fact,
Okay.
I spoke French before I got there, actually. So they made fun of my accent because I actually have a Parisian accent. So I was the American with the French accent.
That's okay. The Quebecois make fun of us in the West as well, so we understand. Yes.
I think it's very difficult. Kim's diagnosis, at least it started out as some form of trigeminal neuralgia. And there's something called the trigeminal nerve. And under certain circumstances, that nerve will cause a lot of pain. And it's a very specific, nasty, sharp, intermittent, frequent pain, and often triggered by movement, And that trigeminal nerve provides sensation to the face and also some strength to the muscles of the face. But this is a rare condition, and I looked it up actually, and it is misdiagnosed initially. In other words, you go to the doctor with this almost half the time. It's very, very commonly misdiagnosed because it's not a common problem. And like Kim, very often it's presumed to be a dental problem because it's mouth pain. It happens when you eat. The obvious thing is, well, it hurts when you eat, right? It's in the mouth. Must be a tooth or a root canal or an abscess. And very often people will have teeth removed. And I know, Kim, you had some procedures done to try and alleviate this, and they don't work. So that's pretty uncomfortable for the patient, and it's a waste of time, and it's expensive. And then you're right back where you started from, if not worse, because none of that has helped the trigeminal neuralgia. And Kim, I think they found in addition, in your case, you had a cyst, which is even more rare.
Yeah.
And so, if you have to pick, it's a lot better to choose a disease or disorder that isn't rare. Pick something like diabetes, that everybody has, because you go to the doctor and they go, oh yeah, diabetes, I know what to do. We'll measure your blood sugar. We've got all these medicines.
Being a guinea pig bad. Got it.
Yeah, particularly if you live in a rural area, right? You want to live in Montreal where there's a big neurologic institution, or New York City. You don't want to live where there's a lot of cows, right? That's not the way to get, state-of-the-art medical care. So I think, the deck was kind of stacked against you. You ended up with something super rare, and you're in a relatively, unsophisticated area with GPs. And, if you're surrounded by neurologists, I mean, as a neurologist, if I had seen you, probably I wouldn't have seen you till after you had the dental procedure and all of that. I certainly would have thought of trigeminal neuralgia. It would have been on, one of the few things that this could be. But, on day one, maybe not. So that's what happened. So this is not at all unusual. And I wouldn't say that this is a, quote, failure of the healthcare system. This is just kind of what happens when you have something very, very unusual and you don't have enough trained physicians. Now, you could say that's a relative failure. How come we don't have more experts, right? So the way to have more experts is to train more doctors and encourage them to live in more out-of-the-way places. And that's one way to improve care. But, having something that's, first of all, it's painful too. So I understand this has been a kind of a long journey, but I sense that you have met the experts now who at least understand what the problem is. Yeah. And in neurology, that's more than half the battle, but there's not always an easy solution either once you know what the problem is. But I tell my residents, I teach at the medical school here in Memphis, that, until you have a name for the problem, you're just floundering. You need a name. What is the diagnosis? You go, aha, it's trigeminal neuralgia. Okay, now I can look that up and see what my options are for treatment. But if you don't have a name, you can't look it up. You don't know what you're doing. You're just, floundering. So it sounds like at least they got a name finally. So that's,
and yeah, I think like Doctor, part of the issue, and you'll have to excuse me, like with my almost dystonic like tremor, this is what it looks like.
Right. Now that's not a typical part of trigeminal neuralgia. So I would call
no. What I do, I've got a sensory bite chew sometimes that I just almost like a shock absorber, right?
Okay.
It just calms it right down. So in the movement disorders field, that was the fact that I was doing that. They thought that was a geste sensory trick, right? But it was more than that. So my where I'm at right now is I've been released from the hospital for a few days, and this Friday I am meeting with a skull-based neurosurgeon who specializes in exactly what we're looking at. It is a symptomatic arachnoid cyst, 1.5 centimeter, mass effect on the trigeminal rootlets, V3 motor nerve, relatively pain-free variant, meaning that it's in a rare place, it's a rare presentation. The fact that the shooting pain isn't really that prominent, which would likely mean that it's more on a motor nerve than a sensory nerve. But yeah, it's causing just a ton of left side weakness, difficulty eating, definitely difficulty speaking, and impaired jaw movement, as well as some impaired proprioception. So yeah, it's a complex one. It is an onion that the neurosurgeon will have to unpeel. However, I spoke to him on Thursday, and he is already talking with a team of colleagues, and they're hopeful. They're hopeful that they can really figure this out. But in the meantime, it is as miserable as you say.
What do you think
Absolutely.
about the tremor? What do they think about that? Is that a separate issue?
Well, the MRI, the latest MRI, it showed significant left side muscle atrophy. And so it's kind of my theory that a lot of the tremor is just muscle confusion. It's just kind of creating a situation where both sides are trying to compensate, and it's just having a difficult time. So you're right. That is, and the other thing, the other mystery right now is MRI in 2023 and 2025. The cyst is present and visible in both images, and hasn't grown. So the mystery is, why have the symptoms progressed if the cyst has not grown? And so right now, that is the mystery that the team is looking at.
Okay, well, it sounds like a step forward. You identified a neurosurgeon who looks at the scans and
Yep.
understands what he's looking at. And if the cyst is responsible and they go in there and remove it, this is potentially fixable.
Sure.
So fixable things are always good. It's not going to be an easy fix for sure. And I'm not sure what he's told you, but I suspect that a lot of times in neurosurgery, the goal is to keep it from getting worse,
Yep.
as opposed to necessarily making it better, although that would be the hope. I think that's kind of hard to predict.
Yep.
He's probably going to want to write you up as a case report. Did he tell you I've got 10 other patients like this, or what?
No. He said that this is not the kind of thing that they see very often, and as a result, he's really going to have to lean on his colleagues for their guidance. So, and he's got a ton of questions for me as to when this started, why this started, and so on. And arachnoid cysts are generally non-symptomatic and benign, and rarely cause problems. But when it is in a highly nerve dense and really important area like the Meckel's Cave, you have to be positive what you're going for.
Kim, you had said originally that
Yeah.
you'd gone back to a volleyball experience 10 years ago
Yeah.
in our first interview, which I know, Doctor, you had seen that when I sent you that interview. How feasible is that was the cause of it? Is there any medical foundation to that?
It is. If it is, like I say, an arachnoid cyst generally doesn't really do anything. It's an incidental finding. But in my case, something happened around 2015, 2016 that seemed to have caused something to happen. And, as my recollection, I do definitely recall around that time, a few months before the symptoms began, that I did have a significant head impact with a spiked volleyball. And so, I mean, that's the only head impact that I could identify that might have, caused an event which would, maybe alter the flow of that CSF, as the doctor may or may not disagree, could have happened.
It would be unusual, but you're already in sort of the zone of everything is very unusual, right?
Right.
Usually trigeminal neuralgia is just sensory, like we talked about. It's just pain. And that pain can be very difficult to treat,
Sure.
even with surgery. So to have motor involvement is already unusual. And then to have a cyst on top of that is unusual. Now, how the cyst got there in the first place, usually cysts are not post-traumatic. You're just born with them and it's
Right.
a cyst. It's just this little collection of fluid that the brain will grow around. So it doesn't really cause a problem. But it can, and it may, with time, things evolve. So it may have. I think if the surgeon didn't think the cyst was responsible, he wouldn't be too enthusiastic about going in to take it out.
Right.
So he must have a pretty
Yeah.
confidence that that's part of the problem.
Well, and there still is more diagnostic work to do. I am booked for a V3 nerve block, which
okay.
which hopefully will shed some light on the situation. And so that's where we're at right now. I mean, hopeful, excited to see the doctor finally this Friday. And it sounds like he plans on being extremely thorough in figuring this out.
Doctor, what are the potential long-term consequences of delaying his treatment in a case like this?
Well, nerves are very small and they're very fragile and they don't heal well. So that any injury to a nerve, the longer, say, there's compression, right? There's pressure on the nerve, it's getting squished. The longer that continues, the less likely it is that if you fix it, you remove that pressure, the less likely it is that nerve is going to recover. So if it's been a week, okay. If it's been 5 years, the chance of recovery, it doesn't just re-expand, like a balloon and then start working again. So so in general, with a neurologic problem, a spinal cord compression, something like that, you want to fix it ASAP. If you think a fix is going to help. So I would say the longer this goes unfixed, the more likely that weakness in your jaw will persist. Now, with time, you may strengthen it and improve, and the pain symptoms may get better, and things may just be fine. But, a day here, a day there doesn't really matter. At this point, this has gone on for several years, right?
Correct. Yeah.
Yeah. So I would just take whatever time it needs to make sure they get it right, because you only want to go in there once.
Yeah.
And as you said, it's a small area, and the skull base. When you're dealing with the brain, there's a lot of important structures. And sometimes just getting at them, there's a lot of things in the way. So you kind of have to figure out, how do I get in there to get what I want without injuring anything else that happens to be in the way? So there's a lot of other critical things there.
And according to my neurosurgeon, the most common way he has of getting into Meckel's cave is through the nose. And thank goodness I have a big one.
Right, so he'll take advantage of the holes that are already there, right? That's part of modern neurosurgery and surgery in general, with laparoscopy.
That's also how they used to mummify people, but we're not even going to go there.
Right, Right.
We're not there yet.
Not there
I
yet.
hope not.
You're right. I hope not. No,
Yeah.
that's right. So I think that's very sophisticated because in the old days, they would have to do a craniotomy and remove part of your skull and start digging around there. So if you
Or the
could,
fossa, right?
right, go in the back. That's
Yep.
right. And these were big, big surgeries. And obviously, the bigger the surgery, the bigger the chance of some complication, infection, or a patient drops their blood pressure. The longer you're in surgery, the more time there is for things to go wrong with other parts of your body that aren't happy, like your heart and your lungs and your kidneys and your liver. So the quicker you can get in with the least amount of damage, right, to the body, what they call minimally invasive surgery is the term. And so going through the nose, like pituitary gland surgery, it's right in the right in the middle. And they used to have to take a craniotomy, take a big part of the skull off, move the brain apart and go down there to get it. And pituitary tumors are fairly common. Well, somebody figured out you can go up through the nose, and the pituitary is actually just sitting right there, sort of inside the skull, kind of behind and above the nose. So you could just go in there and fix it with the right tools and pull it out, and the patient's good to go in a few days, as opposed to weeks and weeks with a giant surgery. So the advance in tech and training for neurosurgeons is a big plus, rather than having this done 30 years ago.
I appreciate your insight, Doctor. Thank you. Thank you.
Doctor, I'm curious, just for some back information here. Kim, you had your jaw broken 2 times, if I'm not mistaken, because you had a large underbite originally, correct?
And that speaks to the misdiagnosis that the doctor mentioned. I mean, initially, it was just a muscle feeling like I was just losing some coordination in my enunciation. And so at that point, went to my doctor. I did see a neurologist who, indicated that it was far too early to really know what might be happening. I thought that was a clear indication that it must be structural. And at that point, yes, I did have a class 3 underbite.
Doctor, is it possible that aggravated, putting aside the time, is it possible that could have aggravated the condition and made it harder or to deal with or made the condition progress faster?
Well, as you point out, I'd say the important consequence of misdiagnosis is exactly that, is loss of time.
Yes.
Because while you're doing the treatment that won't work, you could have been doing the treatment that will work. So going to preparation for surgery, having the surgery, recovering from surgery, all of which time you did the wrong surgery. So big time loss. I think in this particular case, it obviously didn't help, this jaw thing, but where the pathology is really inside the skull. And this is more peripheral. So I don't think it would have worsened it. I think the worsening is that it made the presentation a little more complicated because the jaw is now modified from its original shape, right? So the exam is different. Did that surgery have something to do with the atrophy? Does it have something to do with the tremor? You've introduced another element that's kind of confounding. But in this particular case, from what I can tell, I don't think it was just, it was just you just needed to make a U-turn after that.
Yeah.
I don't think it really created more harm. Just was a big waste of time and effort.
Kim, what have the doctors said on your end about the jaw reconstruction?
Not a lot, but from what I've heard, they basically agreed that the fact that I've had double jaw surgery with the hardware still intact, it shouldn't make an issue. And we're talking about a different area. The sinus area is still a ways away from the skull base where the Meckel's cave actually is. Correct, doctor?
Yeah. I mean, it's all it's all in this area, but the Meckel's cave's over here and the
Yeah.
jaw's over there. So from a neurosurgeon's point of view, it's very far away.
Yeah.
So I don't think it's related to the current problems. Now, I'm interested in your voice. You were a radio announcer, right?
Yep. Yep.
Have you been able to continue, or did you have to stop?
I worked until the end of October. And at that point, the clenching just started to really affect my voice. The tone of my voice remains the same, but the mechanical delivery is different.
Well, I'm very interested as to whether this is the same problem or a different problem. I would certainly, you may have already seen a movement disorders specialist.
Many times. Yep. Yep.
And did they talk to you like about Botox for the?
Yeah. They administer Botox 7 times.
Already been that route. Okay.
Yeah. Yeah. I've probably tried about 12 different conservative approaches.
Did they have a name, a diagnosis? What did they call it?
Trigeminal neuropathy, basically.
Okay.
Yeah. So, well, as far as movement disorders goes, they were completely puzzled. They felt that parts of my presentation might be Parkinson's-like. However, all my other motor skills completely intact.
Right.
Cognition intact, everything else intact. Literally just the jaw.
Yeah, it's interesting.
So they said that my case was not indicative of any traditional movement disorder that they were aware of.
Okay. So you did the right thing. You went to the specialist. They tried what I had suggested, with the kind of thing they usually try, the Botox. I'm sure they tried some medications, and fruitless. Because watching you talk, to me, it reminds me of, musicians can get dystonia, right? There are like horn players where their lips, well, we have a expert musician here, their lips will stick out, or a piano player, they'll get a cramping in the finger basically it's an overuse. The brain decides, you're practicing 4 hours a day for 20 years. That's too much. And you get an involuntary movement. And what I see is involuntary movements of your mouth. That can also happen, of course, in Parkinson's, but you're not Parkinsonian in any other way. So, and dystonia is, particularly musician type dystonia, very, very hard to treat because it's a brain problem. It's not a muscle problem. It's a brain problem that's really not fully understood. Well, in your case, what I would hope is that they fix what they can see that's fixable, right? And then see what happens. And if you're lucky, that all of it may just go away. That would be great. If the jaw fixes and the trigeminal part fixes, but the tremor does not, then you just happen to have the bad luck of having 2 parallel problems in more or less the same area. And back to the movement disorder guy.
Doctor, yeah, I've got a question. How feasible, let's just say the stars go into perfect alignment and somebody comes along and Kim has the financial ability to hop on an airplane and fly into the United States to have this rectified tomorrow with some of the best equipment in the world instead of muddling his way through the very, very difficult Alberta healthcare system. Who would you recommend? Who would he call? Who would he contact? How quick could he receive medical treatment in the United States?
So our system is complex as well. I'll tell you what I would do. And well, first I would just sort of do a Google search of skull-based surgery for trigeminal neuralgia and identify some top names in the country because, or you can search PubMed to see who's been publishing, who's the best guy to do it because this is a very specialized thing. My mom, for example, had a very rare heart condition. She needed surgery, and my brother is also a physician, so we searched around, and it turned out that the guy who did the most of those surgeries was the Cleveland Clinic. So we went to the Cleveland Clinic, and he did the surgery. So it's some background research, but the other thing that I would recommend, and that is now pretty easy to do, and frankly I did it myself because the condition my mom had was genetic, and there was a signal that I might have it too. So I found the best. I found a recent publication was a review article about this type of cardiomyopathy, and which it was a pretty good chance that I had. So who are the world's experts? And one of them was at the Mayo Clinic. So I contacted him and said, hey, I want a consult. And one of the things that the Mayo Clinic does is they'll do a consult just like this at a pretty reasonable price. You send your records, the guy reviews them, and they'll do an initial consultation over Zoom. And that in my scenario, that I got his advice, the tests that I needed, and I said, well, do I need to come to Mayo Clinic for those? He said, no, you can have those done locally and send me the results. So, and then I met with a cardiologist here who had nowhere near the same experience as that guy, but I knew what to tell him, and he agreed that that was a reasonable plan, and we did the tests, and then it turned out that I don't have that syndrome, so I'm done. But that was good news. But the Mayo Clinic will do these teleconsults. So that's probably where I would start. Cleveland Clinic probably does them too, but the Mayo Clinic, I worked at the Mayo Clinic about 10 years ago, and it's sort of a vertically integrated institution, and by that I mean they kind of do everything internally. So you don't get lost as easy. They have their own doctors for everything, and their own secretaries, and their own admin, and their own medical records. So once you get into the Mayo Clinic system, it's very frictionless. Whereas when you're out of the system, the neurosurgeon works for this guy and the neurologist works for that guy, and they're all separate. In Canada, that ought to be at least a little simpler insurance-wise, because you just got one giant insurance company, the federal government. But here you could be insured by Cigna, but Cigna, that doctor doesn't take Cigna. They only take Blue Cross. There's this other old layer of potential confusion. But I would check the Mayo Clinic. Just go Mayo Clinic, .edu, and get a consult with a movement disorders guy or a trigeminal neuralgia guy. And just, it's probably worth a few $100s just to see what they say.
I have to duck out of here, guys. Thank you for the conversation. Well, I've got a call with the doctor coming up soon here, so I appreciate Jeremy having a chance to share my story, and Doctor, your advice and your experience with this.
Kim, best of luck.
Thank you.
You're going to need it. So hang in there, and good luck to you.
Please keep us updated, okay?
Thank you. Thank you.
Good luck with everything.
All right. Yeah.
Before I bring on our other two guests, I do want you to at least let us know what the art of medicine is, which is plastered all over the background, and and tell us where more about your podcast and what you do on podcasts and advocacy for people.
Oh, thanks, Jeremy. So as you could see, I think Kim's case is perfect, is that medicine is not always straightforward. It's not a situation where you can just memorize it, go to school, memorize everything, and the patient comes in and then you know what to do. That there is an art to it. And I'm sure Ali would appreciate that. It's just if you have 10 pianists playing a Mozart piece, it's all going to come out a little bit differently. And there is an art to medicine. And so about 6 years ago, I have a long career in medical journalism, and I interview people for Medscape and a lot of other sites. But there were people that I wanted to interview that Medscape didn't. And I said, here's a physician and he wrote a novel. I want to talk to that doctor. Why did he write the novel? What's it about? Why take the time, the investment? Why do that? So I started doing podcasts like this about 6 years ago. There's about 155 of them now, every 2 weeks. And I look for people that are doing something just a little bit out of the mainstream. I've done a couple on music and medicine, by the way, Ali. There's a new book called Music and the Mind by Renee. What is her name? Oh, I'm always terrible with names. Famous opera star. And she had an interest in music. Renee Fleming. Yes. So I interviewed Renee Fleming on the podcast, and we talked about music and medicine. So that's the backdrop for my podcast, and that's what the green screen does when I'm on the video. So that's why it's here today. But it's a lot of fun, and I've gotten a lot of great feedback from the Art of Medicine. It's a video like this, and it's on all the streaming ones, and it's been growing. I have a sponsor, and it's in fact at 2:00 my time, I'm going to be interviewing somebody for the next episode of the Art of Medicine. It's a guy who he's going to talk about self-discipline and weight loss because he lost, 200 plus pounds, and he's been able to keep it off. And he writes these kind of inspirational books, about how to run your life and how to be happy and all he did was walk. I think he's walked a third of the way to the moon by his measurements. And he's kept his weight off. And so I figure that's going to be a lot of fun. So we'll have a 20-minute chat. So maybe I'll duck off because I got to get ready for that. But this is, Kim, that's a really tough case. If I saw him in clinic, I would be scratching my head. I'd be making a list of other specialists to send him to, like the neurosurgeon and a movement disorder guy. And, sometimes you're faced with trial and error. I think that's his big decision now, as well as this surgery likely enough, this McGill cave surgery, to help me to put up with the risks, because any neurosurgery, there's always a, small chance things are not going to go the way that you predict, and for the relief that I'm hoping. And it looks like it probably is, but it looks like they're not quite there yet. And I would encourage him to get, more opinions. He has such an unusual case. And there is Ali, I'll just say that there is a lot of room for improvement to the system, both here and in Canada. And maybe sometime in the future we can compare the systems, because as you said, Jeremy, I had the opportunity. Very few American physicians who've worked in Canada and U.S. who've sort of seen firsthand and can compare, and there are differences for sure.
I actually did not know that when I contacted you. I was very happy to see that. Ali, I mean, before the doctor logs off here, your travels around the world, have you ever heard of anything remotely close to what Kim is going through?
No, never.
Never. Wow.
No, never. But I think that the real crisis now is that it doesn't matter how rare or how serious or anything. It's a crapshoot out there, really, in terms of seeing somebody in time. But I just wanted to say to the doctor, I would love to have you on my speaker series and compare the system, because we are doing this kind of advocacy. And I certainly had experiences in the US that were really positive, and then I had some negative ones as a temporary resident.
That would be great. Well, Jeremy has my contact info. I'd be privileged to do that. I've gotten more and more involved with advocacy as my hair grays. So
I will forward your information to each other. Absolutely. And Doctor, I was talking to a friend of mine whose daughter is horribly suffering with epilepsy, and he expressed a lot of interest in well. So if you're willing, I would love to have you back on at a later time to discuss that.
That happens to be my area of expertise. I wrote a book a while back, Epilepsy 199 Answers. That was before there were FAQs on the internet, and it's in its third edition now. So I was trained as an epilepsy specialist, and still do a lot of that. So I might have more to say.
And Ali, she is in Bow Island and being tossed around the Alberta healthcare system at the moment as well. So this would probably be something that you could take part in as well. Thank you so much for coming on, Doctor. Ali, did you have any questions for Dr. Wilner before he logs off?
Um, Not so many questions, except kudos and saying I think that more doctors have to stand and speak out, and they have to educate the public about things, particularly in the US where people are choosing food or going to a doctor, particularly in Canada where people are leaving because they can't get in to see. So I think that when the doctors, such as yourself, Doctor, come on and advocate for patients and help patients, it spreads the word that we are in. It's not just Alberta, it's all of Canada, it's all of the US. And for me, the question is do we believe that the right to have timely health care is actually a human right? And I guess we have to answer that. And if we answer that, then yes, then we have to stand up, and more doctors, I hope, will be doing that. So I applaud you totally for coming on today. That was so wonderful.
And
Thank you.
that sounds like a question both countries should be answering from
Yes.
different sides of the
Yes.
perspective. Yes. Thank you, Doctor.
Thank you very much, Jeremy. Thank you, Ali.
Thank you.
Joining us today, we have Denise and Annette, and these are two guests that our advocate Ali Morrison asked to come on. And they have, well, from my understanding, they have been juggled around the Alberta healthcare system, very much like Kim Johnston was, and have got some. Well, I don't know. It sounds almost like horror stories. Annette, you said I don't know a lot about you, either of you. So you said you were an EMT, or you were an EMT. So can you fill me in on your educational background and what you've been through?
Absolutely. Good to meet you today. I'm an old primary care paramedic, used to be called EMT. I'm still registered. I don't work for Alberta Health Services anymore. I did for just about 20 years. I run a private company now, and I teach at Lethbridge Polytechnic in the medical programs there. For background regarding today, on November 2nd, I had a significant cardiac event. I was driving my car at the time and crashed my car. I had more than my share of angels. I was not significantly hurt. And thankfully, I did not hit anyone else. Responders did respond quite quickly, and I ended up at Chinook Regional Hospital in Lethbridge. After discharge, I went to see my family doctor as was recommended. He sent me for more testing, which did find a cardiac abnormality, at which time I was referred to the South Campus in Calgary for a cardiac MRI.
How long ago was this?
Late November.
Oh, so recent. Okay.
Recent. Yep. Apparently, South Campus Calgary does not book appointments by phone, by email. They send out your appointment by Canada Post. So
Wow, sorry, that caught me off guard. I'm like, this is the age where I can do a Zoom conference with people in four corners of the world, and they're using Canada Post. Wow.
I know, like, you just have to laugh because it is just so bizarre. I received my paperwork, and when I opened it, I found that my cardiac MRI is scheduled for April 20th, 2027. 16 months from now.
So so they're making you wait 16 months, and
Yes.
potentially worst case scenario, you could have another event and just
Die. Yeah.
Wow. Denise, do you want to chime in here and what has your experience been?
Well, mine's kind of really long. I've had multiple issues with our healthcare system. And recently, I too am waiting for an MRI on my foot that was scheduled for 2027 that I received the documents for back in October, I believe. So my journey kind of started in 2012, 2013. I I had tingling in the back of my head, and I was concerned it might be some kind of a stroke that was, probably going to happen or something. So I went to see my doctor, and I asked him if I could get an MRI done. And he advised me at that time that, you know, they generally don't approve requests for that through family physicians. And I would likely be turned down. And then he kind of went, well, it's probably just your migraines. I wouldn't worry about it too much. And I'm like, okay, fine, whatever. So I'm not sure if that was 2012 or 2013, but afterwards, you have to forgive me, I have a brain that doesn't work very good right now.
It's okay, take your time.
I had an accident and hurt my foot. And I went back to him and tried to get an x-ray done on my foot because I thought, maybe I have a little stress fracture on top or something. And he goes, well, no, it's probably just your toes. They don't do nothing to help with your toes. And so there's no point in putting you through getting an x-ray done because it exposes you to radiation. And I'm like, whatever. Could I get a boot put on maybe to help it heal? No, they likely wouldn't do that. And I'm like, okay, fine. Again, I left, and I had another little incident with my foot, and I ended up going to a Medi Center, and I saw a doctor there, and I managed to convince him to order the x-ray. And the x-ray came back saying that there was possibly a stress fracture on my foot. And so he recommended I get a bone scan. So I went for the bone scan, and unbeknownst to me, I guess I had a brain tumor in the back of my head in that area where the tingling was, that we don't even know how long was there. And it was quite large. So that particular radiologist told the doctor to refer me to a neurosurgeon. And we all know how long it takes to get in to see specialists. So he said to me, what I'm going to do is I'm going to refer you to a neurologist, and they can fast track you to the neurosurgeon and get you in sooner. And I'm like, okay, sounds all right to me. I went to see the neurologist, and he goes, oh, it's nothing wrong. It's just a calcified meningioma. Don't worry about it. You're good to go. And I'm like, all right. So he says, well, we'll just, do another one in a year and see how things are, and so on and so forth. And then he was suspended for having relations with a patient. So I had a new one come up, and he ordered the MRI. I had the test done. And again, he said the same thing, that it's, likely it's a calcified meningioma. Nothing's happening. You've probably had it for years. And I went, okay. So I think I went for a third one. It was in 2013 when I had the one that I think resulted in me. Well, 2013 is when I found it. It was 2016 when I finally started querying my specialist, because this was the second time I saw the other guy. And I said, I'm kind of wondering, like, what kind of symptoms would a person have with something like that? He goes, well, it's not like the front left thing normally you would think. He goes, it's because it's on the left. He says, you will likely have balance issues on the left side. And then I started thinking, I fell and broke my foot in well, first that was the other one with the toes things. And then I fell and broke my foot in 2015. And I'd fallen down after that. Like I had one of those boots on, and I fell in my kitchen, and then I fell off my stairs I fell about 5 times. And I finally got a hold of him, and I said, I think maybe you should send me to that neurosurgeon. So I get there, and he's like, what took you so long to get here? And I said, well, I don't know what to tell you. He goes, well, like, I said, they sent me to, and I told him what I told you guys. And he goes, well, that was wrong. That neurologist should have immediately sent you to me because this isn't his specialty. And he says, you've got a 40 millimeter brain tumor in the back of your head, and you've got 37 millimeter, and you only have 40 millimeters of space between the skull and that brain, and he said, you are at high risk of having a seizure. I'm thinking of her and her heart attack, and I'm thinking, me, seizure, holy man, like I have a new granddaughter I've been driving around, like this is terrifying. I could have had an accident driving or even at home, and I live by myself. So he immediately ordered, put me on the list for surgery, and I got in, and it was fairly quick, which was good. I had complications with a cerebral fluid leak, and that caused me a lot of grief and strife. But coming out of the OR, you're supposed to go directly into ICU, no bed. Then they made I think it's called negative oxygen room, into a bed for me, and then they moved me to another one, and then another one where there was sticking you in between the beds in the hospital, like no privacy curtains or anything. And I complained a lot about that. And so they finally got me another bed. I was there for a week. And then I came back to get my stitches out, and my incision opened up. And she goes, "Oh my God, you need to get your head sewed up again." And I already had it sewed once while I was in there. So that makes like two, because they had to sew it after the first leak, right? So she goes, "You go in there," and we'll, she sends the third year resident up there to stitch me up. And he goes, "Okay, this is the third time we have to sew your head. If you have to come back again, you're going to end up with a lumbar drain." And I'm like, "Oh, that doesn't sound nice." So I had to come back again for another week, because I did have another leak. And the experience in the hospital was like horrifying, because I found that the nurses were really under a lot of stress, because they, too many patients, not enough nurses. And the hallways were filled with patients that were on beds, and there was equipment in the hallway. And I kept thinking, geez, if we ever had a fire in this place, these people would likely die, because how do you get, your hallways are all clogged with hospital beds. It's a safety issue, in my opinion.
Denise,
But anyways, I did that one.
Thank you for
Sorry.
saying that. That's okay. I just want to, that's a good segue into, I have Dr. Paul Parks coming on after this interview, in a pre-recorded interview, and he's an emergency room doctor here in Medicine Hat. And and what I love is that neither of you are blaming the nurses and doctors, because they are just as frustrated. Ali, like, how many horror stories like this have you heard?
I hear horror stories every single day. People write me, or my doctors. I have multiple doctors myself, and they help me, and they tell these stories. And the doctors talk about leaving and all those things. So do the nurses. Sorry, it's very loud. Somebody's doing something. I'd just like to say that the public really needs to know that this has been building since 2012, this crisis, and the PCs knew it. We FOIPed information from 2012, and they were well aware that after centralizing, so there's a historical documentation through FOIP of the fact that in 2012, it started by centralizing the medics, so that if you have one dispatch in a region, so the day that the EMS, which were the first group of healthcare workers and first responders to collapse, was May 5th, 2022. And that is the day that we had a deep, deep code red in Alberta. It was the first time ever in this country that there was no ambulance all through Alberta that was within a few hours of responding. And if you called 911 on that day, they would not answer. They couldn't answer the phone calls anymore, so they stopped. Next, the nurses have collapsed, and that happened. That's been building up again, and it's been known. FOIPing shows us that this chaos and ensuing collapse was happening for years, and they did nothing. So then in 2023, really, it started collapsing for nurses. So 2022 for EMS. So these are the first responders who respond to your phone call. And when you really need help, they're not arriving in time, and they're still not arriving in time to save lives. And then what happened, they killed off the medics because there aren't enough. And so people forget those first responders who are going to make life and death situations like that when they come to you. Those are the people who are the bottom barrel. They get the least amount of therapy support systems, and they're crashing. And it's estimated that anywhere from 85 to 92% of paramedics are walking around with PTSD because they're forced to work in inhumane conditions. They are sometimes working 20 hours, and they go from what we call a bad call. And forgive me if this offends anybody, but I have to say this. A medic went to a call about baby deaths, pediatric. And those are bad calls for anybody, especially if you're a dad and you have kids. Or a neighbor and you don't know where that call is coming from, if it's somebody you know that you're responding to. And then he was told, he asked to take the rest of the night off. And his supervisor had to order him back to work. And he went out and then he hit a head-on teenage car crash. And these are things they work on every day. To explain to the public something called unit hour utilization. This is a ratio of work to rest time, to chatting with colleagues, to making a phone call to the dentist for your 8-year-old, all these things, lunch hour, tea break. Medics have on average 8 to 12 minutes a day, and their shifts are 12 hours and sometimes 20. To make a call, to scarf down a sandwich or drink a cold coffee. They are on their feet all the time and they're failing. So that brings up the second thing that is happening to medics, which is moral injury. And this is a recognized law now. And on this side, you have been forced to work in conditions that damage you because you can no longer do the job that you love and were trained for. They're boomeranging around. They're 4 minutes away from a cardiac and they're rerouted to another part of the town. And then they're 11 minutes away and they're rerouted. And they're boomeranging and they're never getting there in time. And that has escalated. Now this is happening to nurses. They're more and more getting therapy, and they're coming to, they've got anxiety disorders, PTSD, because they can't do the job that they were trained to do. If you go to any hospital in emergency department on any weekend, you'll watch those nurses. The intake nurses are running out from the office. It looks like a field war hospital, and I've been there, so I know what they look like. They're running out, calling a name and holding a paper in their hand. And that person raises their hand, they run to that person, check their vitals, their pulse, their blood pressure, etc., their temperature. And then they run back, and then they run out. And those people run all day. Constantly. So that now the nurses have pretty much collapsed. There's no management. They don't know who's running the show. They don't know what they're supposed to do. And they are now, their numbers are depleting. And now the doctors are collapsing. So systematically, we are collapsing the health system by inaction. I would call it criminal negligence because they've known since 2012, but it's collapsing. So as to the doctors and the nurses and all the healthcare people, they are doing their absolute best in a situation where they cannot win. So
it's terrible.
People need to actually know that every single day, if that's you that has to go to emerge, it's a roll of the dice. It may be a slow day and you get in with an hour or 2 or 3. If you're a critical care, critical situation, you might get in within an hour. But for my example, I have a story too, but I waited 6 hours to get the results of an x-ray. And I had been a day and a half with a complete bowel obstruction. But it took 6 hours because there's not enough radiologists. The radiologists are burned out. In the hospitals, people waiting for surgery, emergency surgeries that are coming in. This is what people have to know. They're working their best, but there's not enough anesthesiologists in the province. So there's surgeons lined up and waiting to do the job they know how to do. And they have to wait for an anesthesiologist because there's not one and they can't go into the operating theater. And that anesthesiologist might come from another town because it's a critical situation. And if he can make it, maybe they can, save that person or that child. So it is a total collapse.
Annette, you're sitting there very patiently. You look like you're going to pop. I just thought I'd add that because you got a front row seat. You were an EMT. Besides the patient perspective, I could see the frustration building, and you got a front row seat to this. Please tell me from an EMT perspective, were you working to see this actual collapse happening in the middle of it, everything that Ali just was talking about?
I was fortunate enough to take my chances, and I left AHS in 2015. But I was involved in that initial provincial amalgamation of EMS that started in 2009, and it was an absolute nightmare. We saw response times deteriorate. When dispatch got moved to Calgary, there were issues with dispatching the wrong units and in the wrong areas, and not dispatching fire departments at all to like motor vehicle collisions.
And that's first responder, correct?
Yeah, I specifically remember an incident, and I won't give a lot of details on it, where we were called to a single vehicle rollover. We get on scene, there's entrapment. We don't carry the tools to cut a person out of a vehicle. That's
Right.
fire department.
Yep.
And initially we were told, oh yes, fire department's en route. And we waited and we waited and we waited. And finally it was, oops, forgot to dispatch fire. There was a 16-minute lag time between when EMS arrived on scene and when fire arrived on scene. That could have killed that patient.
Yes.
And that was because of looping around between dispatch departments because EMS got moved to Calgary. Call after call. I'm not sure if Ali worked when we did the, I can't even remember what it was called. Let's use Medicine Hat to Calgary as an example. Because we were having trouble having units staying in our own areas, I worked in Medicine Hat for a while. We would transfer a patient to Calgary, and then we'd get stuck in Calgary for the rest of the shift, responding to calls in Calgary. We couldn't get home, which then leaves Medicine Hat short another unit, which then delays more time, right?
I didn't even know that was a thing until now.
We would drive to Brooks, drop off our patient. Brooks would drive the patient to Strathmore, drop off the patient. Strathmore would drive it to Calgary, and we would hip hop this patient and hand them over numerous times. That increases the risk to the patient. That increases the risk of vital information not being transferred. And as frontline workers, AHS hated me because I was in lots of meetings and I was always the one who went, how does this improve patient care?
Yeah.
And I was inevitably told to shut my mouth. And that was one of the reasons I left. I just want to show up and do patient care. And that wasn't possible because of the way it's deteriorated.
I'm hearing a common theme from every single person I have talked to, and that is just utter confusion in the medical system. This is the constant theme, and I don't understand where the disconnect is, and I would argue to say at this point, neither does Premier Daniel Smith, because I don't think she's a horrible person. I don't like villainizing people. But damn it, Premier, somebody is not doing their job properly. There is utter confusion in our healthcare system. Where, in your opinion,
stops there.
Yeah, exactly, right? I mean,
Exactly.
Exactly. And that's what it comes down to.
I was going to say, my other experience that was probably life-altering was our shortage of doctors. Because of the fact they cut the doctors' contracts in 2021, I think it was. And we had a lot of doctors exodus from our province. My doctor's clinic lost probably 6 or 7 family physicians at least. And so his patient load has multiplied exponentially. And I went from waiting a month to see him to 3 months to get in to see him now. So it's pretty difficult. And I had a knee replacement done in 2023, sorry. And as I was doing my exercising, I'm going, I'm having back issues. What the heck? So I asked him to order me an MRI. So we did. We ordered the MRI. And I never heard back from him afterwards. So I'm like, well, it must be nothing. Don't worry about it, right? I had breast cancer in 2018. And I had a a full double mastectomy done prophylactically, and ended up finding that I did have cancer. I had breast cancer, I had ductal carcinoma, 2 invasive tumors in there. Had a little bit of trouble with the meds they put you on, and so I had to stop doing it. But I never got to see an oncologist. I saw a nurse practitioner, and I never thought much about it. I went, wow, this place is busier than crazy. The lobby is like packed, standing room only in that section of the breast cancer area. So I did the meds, couldn't take it, so I stopped them. Talked to her about my options. I wasn't given any. So I just went away thinking, well, you caught it. It's stage 2. You're good, right? So you should be all right. So fast forward to 23, the MRI gets missed. I'm thinking he's, just nothing there to report. So that's why I didn't hear from him. And then within like the year, I started having problems with my back again because it kind of subsided a little bit. So I had a new one done, and I got my results back, and the radiologist had actually highlighted on the top of her report that if I hadn't heard critical testing results, if you haven't heard from your doctor, you better call them like right now. And then I started reading the report, and I had cancer spread everywhere. It went into my bones, and I didn't know. And because we missed that MRI from 2023, it had come into my right hip, and it was a 2.0 centimeter lesion. And when I got the second report in 2024, it was now 4 centimeters, and it moved into my sacrum, it moved into my spine, and my skull, my humerus, like it's everywhere now. So basically I'm palliative and you can't save me anymore. And that's because he is so bombarded with patients that he missed that freaking report and didn't call me. He didn't see it. So now I've got what I consider to be a death sentence.
Ali, I mean, you said that this is potentially bordering on neglect. How foreseeable was this in your opinion?
It was charted by FOIP since 2012. 1 medics, 2 nurses, now the doctors. So the issue is that people really need to know is that everybody has a breaking point, and the doctors are now being stretched past their capacity to do the job. And I saw this in other countries I've lived in, even Ireland, my home, where a 2-tiered system, there's not enough radiologists, so they missed breast cancer. They missed other things because they're all overworked. And we know individually, those of us who've had to work for any prolonged length of time, 12 hours a day even, but for long times, no times off, we all make mistakes. We are going to, and we are going to make more and more mistakes, and people are dying every day.
Ali, I mean, what do you have to say to the inevitable comments that I know are going to come underneath this video of blame the federal government for letting in too many immigrants? Because I know that's what's coming. I've seen it 100 times. And of course that is going to be a small factor, but I follow media all over Canada and the United States. I follow dozens of little independent media outlets in rural Canada, and I'm not hearing horror stories from all over Canada like I am in Alberta. I mean, Alberta seems to be a very unique place where things are definitely disintegrating faster than the rest of Canada. So my question is, how, and in all fairness, Alberta has been the fastest growing province in the country. So, you mean, how much of this is provincial and how much of this is federal?
None of it is federal because the federal government gives us money. Yeah. Some of that money is going for other usages right now than healthcare. Secondly, 2012, right up to 2025 has been FOIPed and looking at the stats. They knew what was happening. The NDP were in for 4 years. They tried to make changes and they were vetoed and all sorts of stuff, but they did put money in. But if we look at this historically, whoever's in charge, and the UCP have been in charge the longest, would see that this is happening. They took money and put it in other things. We have been waiting for new hospitals for a decade. Daniel Smith invited 1 million people to come to Alberta. To blame immigrants and refugees is disingenuous. You have to have, you can't want to build the province and not look at the infrastructure and bring in new doctors, new nurses, and new hospitals. And they have known this for over a decade, 13 years. And Danielle Smith.
Actually, I'd say 30 years they've known that this is going to be a problem.
So the issue is not immigrants. The issue is money. You choose what you put your money into, and either you put it into a public system or you put it into private, which is what is happening now. Buildings are being sold. There's contracts with companies who have American bank accounts. And we know what happened from the 3 deaths in Edmonton a week, 2 weeks ago. That was a private hospital, by the way.
Edmonton was asking the premier to declare a state of emergency, if I'm not mistaken.
And it is. And of course, she's not.
Yeah.
But we cannot blame other people. We have to say immigrants play a valuable part. This is politically, in my mind, this is just my opinion, but they're playing on division, hatred, not those type of people, not those type of, we don't want them getting our wealth. They are using that as propaganda. It's not true, because you look at any country around the world and healthcare privatizing or two-tier, every single country but Sweden, and we all know Sweden is its own little Valhalla, like how they do it is amazing. But every other country that has two-tier health services, the public people suffer far greater losses.
Oh, sure.
Every country that does not put their money into healthcare and education as their primary infrastructure suffers more than any other countries. And as regarding Canada, by the way, you can FOIP for free in Ontario and other provinces. Only in Alberta are we paying $25 for a FOIP. And I just have to say, and those FOIPs are coming back now redacted. And
oh yes, she's actually prevented them from anything that has to do with her is you can't even get it.
Yeah, we can't FOIP a lot of health stuff now, right now. But the problem is we are far worse than any other province. Yes, other provinces are struggling, but Alberta, hands down, in so many areas besides health, is absolutely the worst, in the worst chaos. And when Dr. Paul Parks tells us that we have maybe a year to reverse this, he's telling the truth. And we have to listen to him, and we have to get everybody in Alberta who has the ability to go to one of his talks has to get out there, because what we are hearing in the news is not true. It's just not true.
And my interview with Dr. Paul Parks is coming up after this. And again, he one of the things that he said is nobody knows who to contact to ask for help anymore. It sounds like it's chaos on every single level. Annette, very quickly, you wanted to add something here, and then I have a question for Ali here before we wrap up.
All right. 3 real quick things. Back to immigration. I always find it interesting when people try and blame immigration and the federal government for that. They might want to look at March 2024, when Premier Smith wrote to the federal government demanding that the feds double Alberta's allotment of immigrants. They might want to look at August 2024, when Danielle Smith was on the Sean Newman podcast and stated that she wanted to grow Alberta's population to 10 million using immigration. And as was already said, the Alberta is Calling campaign. So it's disingenuous to blame the feds for everything. We need to look at what our province is doing as well. For me, something I wanted to add, as an instructor in EMS, what is going on in Alberta is very difficult. It is very hard for me to stand in front of my students and tell them this is a good career when I know it's not.
No kidding.
What those students are going into right now is horrific. And I don't know how to tell them that. You know, I can't encourage anybody to go into any medical career right now because it's awful.
That's the other thing, because we can't even bring in people into Alberta. You've got all this separatist crap going on, and they're like, what do I want to go there for? It's a disaster, you know.
Exactly.
You know, like you figured the US is I can't even believe what the US is like right now. And then they look, well, let's go to Canada. Oh no, Alberta. No, God, forget it. Like that place is a gong show right now. And it's who would want to move here for a doctor? 17 doctors went to BC that I read. 17. Okay, that's a fair amount from Alberta to that. And as far as immigrants go, in 2024, we had 50,000 people that moved here from Ontario and BC alone that were already citizens of Alberta. I mean, citizens of the country. So, I mean, and being a person with a brain in your head, at least I would think you would have a brain in your head. If you were going to start doing this, come on down to Alberta, we want you to move here and all that kind of stuff, would it not make common sense to go and look and see what numbers are waiting to come here from people that are legally immigrating into our country at the time? Like, do some homework before you start running around and trying to invite people to come here. And the other thing was that the largest numbers that come into our country are people coming here on work visas, and they often bring their families. That was the largest number I saw online, and that number, like those people were significant, right? And most of those people come here to work in things like the oil and gas. They come here because they need laborers and stuff like that, and people with skills, engineers, all kinds of stuff. They come here with that background, specifically, mostly for the oil and gas. And then the next highest numbers I saw were students that were coming here on education visas. And the smallest portion of the people that were coming into the country were immigrants that were seeking asylum. So you know what? That's just a bunch of bull anyway, as far as I'm concerned.
Ali, so what is the solution, Ali? Like from your perspective, if you and Dr. Paul Parks both agree that we have a year before we're literally people are dying in their home dialing 911, because that's already happening, just for the record. So what is the solution here? Do we have to, beg Prime Minister Mark Carney to send the Canadian military in and set up some tents like during COVID? Will that be a
Yes.
solution? Because you know what, I'm all for that. To heck with what the conspiracy people think about them funneling us into camps. If we have to ask the federal government for help to get through this crisis, then I'm all for that, because I've lost track of how many people are dying and suffering. Didn't you tell me a child died in Cochrane because of something recent?
Died of an asthma attack, and the urgent care center here, which Peter got 3 years ago, told me, get it out of your little head. There's never going to be a hospital here, and we have 38,000 people here. And a little girl who was under the age of 6 had an asthma attack, and the urgent care here closes at 10 because there's not the money to fund them 24 hours, and they don't have enough staff. And so they had to go to Calgary, and they didn't make it. There's numbers of stories of that. So one of the things you asked, what can we do? First of all, the main question that every single person has to ask again, and it's nonpartisan, it doesn't matter who you voted for. Do you believe that it's a human right to get care when you are hurting and suffering? And if you do, we do have to write letters. People are writing the federal government saying, how long are you going to let this fascism run the country? We are writing. But Mark Carney probably is on a tightrope every day of his life. So who knows how far it will be allowed to go. But second, what we have to do is join a grassroots organization. There are numbers of them. Friends of Medicare, join them and know what's going on. Join Alberta AB Resistance, abresistance.ca. It's a group that's working on recalls, because that's a legally available option to restructure the power structure of this government. But other people, what I personally am doing is I just want people to know that Daniel Smith has been in office 1,185 days. It's not getting better. It's just not getting better. And
That's what everybody is saying.
Course, and she is not going to change. And so this privatization that is happening underneath our noses, it's announced after we even know about it. She is not a leader that is true to her constituents' needs. She is not listening. They have cut off any form of communication avenues available. You can email, you can phone, you can show up at an office. You're not going to be heard. We are invisible. So the grassroots movements are the way to do it. If there's a rally, I'm appealing to everyone. You may never have belonged to an activist group. You may never have done anything or gone to a rally. But never before, more than ever now, if there's a rally in your community or your town or your city, you have to get off that chair and you have to be there, because the media does capture how many people are there and how upset we are. Secondly, what I am doing in conjunction with Dr. Paul Parks is something we did with the EMS. So if anybody who's listening, you can email EMS Safeline, EMS Safeline, Safeline @gmail.com. I am appealing to the public, no matter how painful, and I know how painful this is, to talk about experiences. But if you have lost a loved one, if you have suffered complications in your health, or you've suffered more in your health because you could not get the health care you needed in time, please write and tell us your story. We're collecting those stories. They're going to be documented, and in the hopes of that I can work with Dr. Luann Metz or Dr. Sarah Hoffman or some MLA in the opposition to get those names and those stories, what we call tabled, in the Legislative Assembly. And we did it with EMS, and we took some EMS up there, we gathered their stories, they told what they were exposed to, what they were suffering from, and we tabled it in the Legislative Assembly. And to those who don't know what that means, it means that that information is a historical document that is permanently in the records of the legislature, meaning even Danielle Smith cannot take away those numbers and those names and those stories. And that's what we want to do. We want to bring that to legislature and have them acknowledge however many hundreds of stories we have, in the hopes that those people who have suffered, and mostly the people who lost their lives, are documented and their name will not be forgotten. Because right now, this government has stopped, as of a month or two ago, they have stopped recording deaths due to unavailability of healthcare.
I heard that.
Those names are not being recorded. So we want to change that history and have that documented. So that's the first thing. The second thing, if you want to know more about the issues, there's something called thespeakersseries.ca. And on that, people like Dr. Paul Parks, he's been on twice now, people like Dr. John Meddings, people on all the issues that we're concerned about in this government. These are experts in their field, are giving presentations like Dr. Parks is going to give after this. Go and find out where they're talking, and show up in spirit, and show up in person, and do whatever you can to be heard with a group of people, because we are being silenced. So we need to do group actions now, and you need your stories to be told, and that way they cannot erase those stories.
Ali, you're very well cultured. You've been in multiple different countries, worked in different environments, in different medical systems many times. Where would you say the Alberta one is ranking right now in all of your experience?
From my own experience as somebody who knows what's going on and who delayed going to the hospital, couldn't get an ambulance. My partner had to drive me because there were no ambulances available, with a live IV in my arm and a chart on my lap and everything that ensued. All the years that I've been researching this, what I saw in that hospital on that day was a war zone. And all you have to do is remove the nice floors, the clean walls, and you will see people rolling clotheslines out with a sheet tied on it, and attending to people in the emergency waiting room, wheeling them in. You will see lines of paramedics still lined up in the hallways. You will see nurses run off their feet who might snap at somebody. You will see nurses being attacked by parents who are out of their mind with panic because their child has been four hours in a waiting room and is really sick. they're attacking nurses, and you will see doctors who are doing everything they can to remain calm and just one foot at a time keep moving forward.
And just to be clear, you actually have
Yes.
worked in a war zone, have you not?
I have.
Denise, I'm so sorry that, about your prognosis. We live in a world of modern medicine, and I sincerely hope you have a long life ahead of you, regardless
Thank
of
you.
the prognosis. And Annette, thank you for your times on the front lines. I know you're in the beginning stages of your medical journey, and I sincerely hope that it is, it's very scary what you're facing. I understand.
I'm more angry than anything.
Yeah.
Hmm.
I think the frustration is the common theme. Confusion and frustration would be the best description of the entire Alberta medical system at the moment. Ali, keep up your good work with Dr. Paul Parks. Thank you for coming on, and I'm sure we'll be talking again. Enjoy the rest of your day, ladies.
Thank you.
Thank you.
And thanks for letting us have this forum to tell our stories. It's appreciated.
I wish I could do more. Just closing thoughts here, just to let all of you know where my perspective is. In 2010, my bowels ruptured because I've had Crohn's disease since I was 13, and I have been on my deathbed. And, this is coming from a place of empathy when I say that I know to a certain extent what you're going through. And it breaks my heart to see people suffering like this because I know I was given urgent care thanks to a very amazing doctor, Dr. Chalmers Nixon. If she's listening, that woman saved my life because she understood priority. But I dread to think what would have happened if I had gotten sick right now, and that's a very scary thought.
Yeah, it is very scary. I mean, I just got my most recent tests and my cancer's spreading again, so I had to do some changes. Might be looking at some heavier treatment to try and knock it back. So,
Yeah, I'm sorry to hear that.
yeah. Not looking forward to it. The one thing I think that people do tend to forget, however, is the cancer clinic and the amount of people that have missed surgeries and end up at stage 4 when they could have survived it because they didn't get their surgeries soon enough. And there actually was a young man that was in his 40s recently that died from his because he had gastric cancer and it went into his lungs and killed him because he was waiting to get in for his surgery. And they said, "Oh, you're young and healthy, you'll be okay." But he didn't make it, and he left some kids behind, 2 little kids and a wife. So, I mean, that kind of crap shouldn't be happening. It just shouldn't be happening.
Yeah, well, age has got nothing to do with health. I was in and out of hospital emergency rooms every 2 weeks when I was 16 with bowel obstructions. So
Yeah,
anybody who
that's
thinks
scary.
anybody thinks who goes by the thought process of you're too young to be that sick, in my opinion, should not be in the medical field.
Yeah.
Yeah.
Well, I mean, like this man's surgery should have been done like expeditiously, like right away. But there's no, like Ali said, we don't have enough anesthetists, we don't have enough people, and in all honesty, they have had so many years where they could have budgeted to build new hospitals, budgeted to build long-term care facilities that would be in place right now, knew about the baby boomers putting an existential pressure on our healthcare system back from when Klein was in till current day today. They haven't done anything to encourage people to help them get into the um, healthcare careers at all. There's no funding to help you with education or anything to promote these types of positions. And without them, you can't run a healthcare system. You can have all the equipment and all the other stuff you want, but if you don't have the doctors and the nurses and the radiologists, your system can't work.
Yeah.
So they're just not supporting it in any way, shape, or form. And I think it's atrocious. And I really, myself, I'm still hoping that maybe somebody will join me and I will go after them in a class action suit for negligence, because that's really what I want to do. That's what I would love to do.
Well, I will make sure I include that request. I was going to cut it off sooner, but that's actually a really good note to end this podcast on. So if you would like, contact me. I'll put you in touch with Ali, and if a class action lawsuit is what it takes for change, then I'm sure you will have lots of support.
Yes, I think we do.
Thanks very much.
Thank you. Take care.
The following interview is part 3 in our journey through the Alberta healthcare system. I'm joined today by Dr. Paul Parks, an emergency room physician at Medicine Hat Regional Hospital, president-elect of the section of emergency medicine within the Alberta Medical Association, and a longtime healthcare advocate. I've asked Dr. Parks to come on today to talk broadly about navigating Alberta's healthcare system and how, if in his opinion, it's become more complex and how that complexity impacts patient care, as well as punctuality on the emergency side of our healthcare system. Just to be clear on the onset, we're talking about the system in a general sense and not any one specific patient or case. Dr. Parks, thank you so much for coming on today.
Yeah, thanks for having me here. Yeah, I'm just happy to chat about what's going on in our system and give a kind of an overview of how we've seen it changed and how it's getting a bit more difficult to navigate for sure.
So, from your perspective of emergency medicine, how hard have things become to navigate with that? And Premier Daniel Smith has made so many changes recently. And what is that doing to you guys in emergency?
Yeah, I mean, well, it's very important to understand and just kind of outline that, in the last couple of years, it's been endless change. There's been a lot of chaos. Like this government's been in here since 2023 and just, one change after another. But one of the biggest things they did is they totally blew up our integrated healthcare system and created 4 different silos and different pillars. But actually, reality, there's more like 11 different kind of silos with their own CEOs. And because they forgot about health care and they found public health, sorry, they forgot about cancer care. They forgot about a bunch of pieces that, they didn't fit in their original pillars. And honestly, as this has been going on and on, it's been endless change, and it's been extremely difficult for those of us in the system to even know how to navigate it. And all the healthcare workers are, many healthcare workers don't even know which silo they're in. Are they in the primary care world? Are they in the acute care world? Are they in the recovery Alberta mental health world? They have no idea because they work in a bunch of them. And then if you think about that, though, that it's really hard for us in the system that's in it every day, amplify that 100-fold or more for patients that are trying to get into the system, trying to get help, trying to get care navigating it. And then add, another big confusion and amplification factor if they don't have a family physician and a primary care provider that can kind of quarterback all that. So that's a long answer to say it's been pure chaos, endless change, and a lot of the system changes now have made it extremely difficult to give safe and timely care to a lot of Albertans.
Would it be safe to say this is directly impacting patient care?
Oh, no question. It is. I mean, part of this is going to be, at the start, it was let's be patient. Let's see if this all kind of fits together. And right at the start, I was, I'm speaking just on behalf of myself and my experience, but having talked to a lot of my colleagues across the province, but also I was there as the president of the EMA when they rolled this out. And I was very clear to them and said, listen, if this is the plan and you're not going to move off this, you're not going to change, then you should be very clear that if there's no integration and or operational control or ways to connect these silos, it's gonna be next to impossible. And here we are 2.5 years later, and those still don't exist. People don't know who's reporting to who. Nobody knows how to make connections from, say, the primary care world or continuing care world or the mental health world, but to our acute care hospitals. And then again, too, they've shuffled so many resources and moved things around so much, and now they're creating new entities like, as I mentioned, cancer care, and there's EMS is its own entity. All these new entities that they keep forgetting about, they plug them in. They're their new things, but forgetting that they all fit in each of those silos and have to work every single day. And I'm speaking from Emerge side. So from the Emerge point of view, I'll just say it very bluntly. We see the sins of the system. We see where the system doesn't work. And so as soon as it doesn't work for a patient, even if they have a primary care provider, they'll get directed to come to the Emerge because that becomes the safety net of trying to say, okay, we'll go to the Emerge and see if they can sort it out because we can't figure this out. We don't want your condition to get worse. So every single day I'm seeing that and interacting and hearing that like regularly, basically from lots of patients.
It's my interpretation of what you said is that you almost sound like the emergency room is a little bit of a scapegoat, but at the same time is if we don't know what's wrong with you, go see emergency and don't die until we figure out what's going on. Would that be a good takeaway?
Yeah, I mean, it is honestly, because it is the safety net, but as the system's getting, it's more disintegrated, more disconnected, more difficult to get through it and to access care. The safety net is the only place left is the emerge. And so I'll give some real examples. So for example, say you have a mass in your abdomen, you don't know what it is, you have a family doc and they're like, oh, I'm very concerned about this, I'm going to book a CT scan, and that scan can't be done for weeks and weeks and weeks. You go back to your family doc and they're like, no, I'm concerned your blood work's getting worse, I think we need to speed this. You should go to the emergency department because maybe they can speed that up. And or say you have an operation and you have some post-operative complications or questions, and you can't get access to your operative team or your surgeon. So you call their office and they're like, oh, just go to the emerge. The emerge has become the safety net for every piece of the system now, and it was never designed to do that. And as the system is more chaotic, as it's broken and not working and disintegrated, more and more and more, we're seeing patients come to the emerge to try to seek care when we're not the best area to provide that care.
So I know you can't speak about any one specific patient. You are local to Medicine Hat, so we have to be careful with that questions. But you did see my interview that is going to play before my interview with you that people are watching right now. So how common is it to hear stories like this from people and what he is going through? Can you tell me how frequently are these coming up?
Yeah, I mean, again, I should be very careful and say I'm talking about the big broad system because again, there's confidentiality issues, but there's
Yes.
also issues of, not knowing every detail of a specific case and that I wasn't necessarily involved in all the pieces. But in broad,
In a runaround sense. I'm
yeah,
sorry to
yeah.
interrupt you. Yeah.
No, 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 and it's fair. I just want people to understand that. So
Yes.
Kim's case is heartbreaking, and we should be able to do better as a system. And sadly, to answer your question, we're seeing that more and more and more, where patients are falling through the cracks for a bunch of different reasons. And I should say, a lot of times, like speaking in general terms about Kim's, I mean, some of the issues are, it can be very complex rare diagnosis that makes it harder to get a diagnosis, so you need to really have really coordinated care and really good follow-up and really close continuity care. Sometimes it can be things like just that access isn't there in a timely manner as things are clearly getting worse and they don't have a primary care physician to quarterback and make sure things are following up. And then sometimes it is as simple as, on a regular basis, I'm seeing cases where, like heartbreaking diagnosis of new bad cancers, and all I can do in the emerge department is say, for example, okay, I'll just give a made up example of someone with a suspicious mass in their liver, and they see me the first time ever. I don't know them. I'm an emerge physician, I don't have a relationship with them, but I say this seems really suspicious, but we're going to need to get you booked for special imaging, then you're going to need a special biopsy, and then you're going to need to see a cancer specialist if it is cancer, as an example. Well, each of those steps can take weeks to months, with the way the system's working right now, and they have no one to go back to a lot of times to say, hey, is that that imaging that was booked, is that follow-up, that referral that was booked, are those tests that were booked, are they all getting done, is someone going to call me, what happens if I don't hear through it? Like those kinds of examples are happening every single day because our system is so disconnected, so chaotic, and so difficult to navigate right now.
Would you say it's progressively getting worse, or has it reached a turning point yet?
So we've been trying to be very patient for the last couple of years because we were promised that, this will get better. But a couple things from the front lines, it's absolutely getting worse. Everybody that I speak to around healthcare workers on the front lines, it's very chaotic. It's never, the government called this refocusing, and I've heard like hundreds of times from different colleagues that from nurses, physicians, everybody in the system, that it's never been less focused ever. It's never been less connected and clear what the path is. And now we're seeing, add on top of that, yes, there are way more patients in Alberta, people living here, there are more patients, but yes, in addition, there's almost 1 million people that don't have a family physician. So there's lots of things complicating it, but then you add a really chaotic, disorganized, environment that's just been endless change. And the change didn't even have a change management plan. The premier just said, I'm going to blow up AHS. Here's 4 new pillars. I'm going to spend hundreds of millions of dollars on consultants labs to try to figure out how to make these four pillars work. And 2.5 years later, we're hearing more and more and more bad cases and bad outcomes and difficult navigation of the system because it's still chaotic and still very difficult.
How much control do you actually have? So, scenario here. Patient comes into emergency, sees you, you obviously know there's something wrong. You write a prescription. I've been in emergency before, so I'm just going through my own scenarios here and says, "Well, you really need to see a specialist." When that patient walks out of emergency, what can you do from that point forward?
Oh, there's a couple pieces. So, I mean, and a lot of this is simplifying, but one right away is our job in emerge is this life threatening, life or limb threatening? Is this something that I got to deal with like in seconds to minutes? The next one is, okay, is it very serious? Is it something that I'm really worried that I've got to, deal with in the next day or two or days because things are getting worse? And then, of course, there's the things of like, is this something that's concerning, but we have weeks to work out? And then a lot of time my job is saying, you know what, I know you've got symptoms and you're concerned and you have chest pain, for example, but I'm quite confident it's not a heart attack, it's not your heart, and reassure people and that it's safe to follow up with the family physician. So there's a spectrum there. But what's happening more and more, to answer your question, is that when I see a patient, sometimes I know now that if they're life threatening, I admit them to hospital, do a bunch of stuff. That's simple, because then they can come into hospital, get access to all the resources that the hospital has. There's consultants on call, all those kind of things. But it's those cases where I'm like worried what's going to happen in the next couple days to the next week or two. Could this person get a lot sicker? Those are very difficult cases now because I can make a referral, and depending on the specialist or the test that needs to be done, it may take weeks, and I don't know how long it's going to take, and I have no feedback on that. I have no idea. Is that specialized test I'm going to do for you? Is it going to be done in the next day or two, or is it going to be done in the next couple of months, and you're going to get way sicker in the meantime? So those patients that have that uncertainty that this could be something that needs to be sped up, we're finding more and more and more we have to just admit those patients to hospital, like where they have to actually get admitted, sit in a hospital for 3, 4, 5 days, just so that we can get a couple tests that we normally would have been able to do as an outpatient. We have to admit them and keep them in the hospital and use resources because we want to make sure that that follow-up and those referrals and those tests get done in a timely manner. And of course, I've been advocating about this for a long time, but we don't have a lot of hospital capacity. So every time we have to do that for patients because the system isn't working, it means there's no space for those really sick new people that need to come in. So it's just a very complex mess, in a way, and it's difficult to navigate. But it's getting harder and harder, and we're seeing those cases more and more and more where we just know we don't have meaningful access to safe follow-up in an outpatient manner.
Yeah, I really do feel for you guys as somebody who has multiple doctors in his family, and my ex-wife is a nurse. I've been exposed to the medical system on many levels as well as a patient, and I've seen how the general public sometimes treats you guys in emergency. And it's so hard because people come in, they're sick, they're in pain, they're not feeling good, they're not at their best. But at the same time, I've seen many posts online, you know, making some of the most horrible comments about our emergency room here. And I really do feel for you guys because it sounds like you're in a state of desperation as well as the general public. So what would you like to convey to the general public here today and ask of them other than just be patient? Like give them your perspective of what your struggles are if you didn't already do that previously in the interview. Does that make sense?
Yeah, it does. I mean, and I should say, I mean, I work in the Emerge. I'm proud of our team. We do some amazing stuff. But often we are quite challenged with our resources and what things we can access, or our volumes, or our space, and can we always improve? Sure. And there are sometimes bad interactions that we can improve on 100%. I mean, it's a complex, chaotic, difficult system, so we don't always get it perfect. But
You're human beings too.
yeah, absolutely. But on the other side, I'll just say, maybe the plug will be, and I've been advocating it in a big, broad, provincial system wise for a long time, is saying that, be patient is really a key factor because every day we are showing up and our teams are showing up and we are, having higher volumes, a lot sicker patients with the same space we've had for a long time. But in addition, we often are understaffed and we don't have as many nurses as we should have, and we don't have the same full team that we should have. And so we're trying. So one of the plugs is that the people that do show up that are trying to help and care, a lot of times some of the things that really frustrate patients and people waiting, I get it. Nobody likes to wait. Nobody likes to sit in the emerge department wondering when they're going to get seen and why did someone else go ahead of them and all these different things. I get it. But a lot of times a bunch of those weights and those things are completely out of our control. And I'll give you an example just even from the last week. I'm going into work this afternoon. I've been working a bunch of evening and night shifts, and for the last week with our increased influenza, our increased sick patients, our emerge department, which has about 20 to 25 care spaces depending, has had more than half of them have been blocked with admitted sick frail patients with influenza or cancers or strokes that have been stuck in our emerge department for days, for that they can't go upstairs because the hospital's full. And when you think about that, just as an example, we have more and more people coming in our waiting room seeking care, but we have half the space to work out of. And it's not like we have, the same amount of nurses and the same amount of doctors to just take care of all the sick emerge patients in half the space, because our nurses have to take care of all those sick admitted patients that are not up on the wards. And a lot of times they take a lot of effort, and they're very time consuming because they need specialty care, and they really should be on the wards and they shouldn't be in our emerge department. So that's an example of what we struggle with. And so when that happens, our wait times are often quite good. But in the last week or two, I've seen patients waiting 10 hours or more in our emerge department. And nobody's ever happy about that. And I'm not happy about it. I wish it was easier, and I wish we could see them better. But it's just maybe putting a little bit of a plug that a lot of times patients don't see what all the moving parts are, and how it's like that duck or swan swimming on the water, and you don't see how furiously they're paddling underneath, right? Like people don't often see that. So
from a patient's perspective, I don't see, and I don't know understand this is when somebody comes in and they've been shuffled around the medical system. They don't have a family doctor. They're not getting the help they clearly need, but they're not in the position where they are truly an emergency patient. What do you do when that patient continuously comes in? Is there a point for that patient to continuously come in? Does it speed their healthcare system up? I'm not sure what I'm asking.
Well, no, I get it. It's the patients that are, things are just slowly getting worse and they're falling through the cracks. They don't necessarily have, a good family physician that can quarterback some of these things, that can, reassure that the wait is reasonable, or inform them that the wait's not reasonable and we need to do stuff. I mean, it's that unknowing and that uncertainty. And I'll just say, yeah, like that's a great example of where the emergency department was never designed to do that. The emergency department was never set up to be, the answer to every part of the entire system that's not working for patients. We don't have those resources either. And then what happens though is that it adds to what you were just asking. You have these patients that are coming back again and again, long waits because they're not necessarily life-threatening at the time that they present that day, and really frustrated coming in. And then often it's hard to add anything to that other than saying, well, listen, I'll try to make sure you're stable and treat your symptoms now, but try to get you sped up to that specialist you need or whatever it is. But we're seeing more and more, as I mentioned earlier, we often sometimes now have to admit those patients to hospital just so we can escalate treatment and work up and diagnosis, or try to connect them to the right service. So, I can just give like rough, broad examples. It could be someone, say they have some, abdominal pain and some bleeding in their stools, and it's going on for weeks, and they have some bleeding, and we know that they're stable, they're not bleeding to death, or it's not something that's life threatening, but we're like, well, that's pretty concerning and we need to get you for a scope. Well, if the wait for a scope of their bowels is 12 months. And, and that's not because our teams aren't working hard or the surgeons aren't doing things quick. It's because that's how long the queues are. And the patient keeps coming back with more symptoms, and we do other tests and still waiting. You can see how that frustration builds up. And the Emerge was never really designed to be somewhere to try to help someone get a scope faster as an outpatient, but that's how this disconnected system is happening more and more, that we have to ultimately make really hard decisions and say, listen, maybe we have to admit you to a hospital bed to try to speed this up. But then I just want to finish with, we don't have the hospital beds. You might end up going and sitting in a hallway for days, because we have in lots of our spaces that were designed for 2 patients, we already have 4. We have a capacity issue, and thankfully in Medicine Hat we're not as challenged as much with that as a lot of the bigger centers across the province. But again, what we see here is when you need real specialized care in Calgary, for example, and you need to see really highly trained, very specialized, physicians in a certain specialty, we can't get you there because there's no space there. There's no availability in those hospitals, and they're super swamped. So it's all connected.
So this is not a Medicine Hat problem. This is an Alberta problem.
Oh, absolutely. I mean,
or dare say a Canada problem.
It's absolutely a Canada problem. Our workforce is a challenge across all of Canada, but that's a cop out a little bit to say, well, hey, it's bad everywhere in Canada, so our government just shrugs and says, hey, no, we're not going to do anything about it. What I'll say is all of Canada is challenged with this, and we're going to have some really frank decisions around, what is our fundamental base of healthcare that we're going to deliver to everybody, regardless of their ability to pay. But in Alberta, you amplify the workforce challenges and the capacity challenges and the issues because the government's just adding chaos on top of it and endless change. And they're also neglecting to do workforce planning. There is no workforce planning in our province right now. Nobody is trying to figure out a coordinated provincial plan to figure out how many nurses and doctors we have and where we need them and how to recruit more. Same thing for capacity. Nobody is looking at, the last time, as an example, the Edmonton zone, the last hospital they had was built in 1988, and they've doubled their population since then. And so it's not just this government. Multiple governments have neglected this, but our government right now currently just keeps adding chaos to the whole scenario.
If to close our interview here, if you could offer, if you have one request from the powers that be, we won't mention Premier Smith specifically, or I guess I just did, but
yeah,
from the powers that be, what would you like to make yours and the patients' lives better every day?
Oh, so stop the chaos. We need to get some integration into our system, but we need to bring back the frontline expertise that our government right now is currently. I'm telling you, like they're spending about $1 million a day on consultants to try to tell them how to fit this system together. And I can't get the actual number. I wish someone would FOIP it. And every time I use that number, the government doesn't even bat an eye because it's in that range, like a couple $100 million a year at least on consultants instead of talking to frontline healthcare workers and experts who run the system and know what every day I see what the experience and the journey is for patients. And so when I go out and advocate about what it looks like in our emergency departments across the province, some Alberta Health, that's not even AHS, Alberta Health government PR person comes out and tries to say, no, what's being seen on the front lines is they're mistaken. It's not really that bad, or it's not like that. So we have to stop that narrative and start to listen to the experts. Let's have some radical transparency. Let's start telling everybody how, what are our wait times for all these key metrics? What are our times to get imaging and see specialists? What are the capacity in our hospitals? We could easily show everybody the picture and just say, is this getting better or is it getting worse with all of the changes that we've done? And then we need accountability, because right now, as more and more people like Kim are falling through the cracks and having difficulty, and we're seeing more and more of it. We don't even know who to go talk to now. Like, there's 4 different ministers. There's the premier running the show from her office on healthcare. Like, there's nobody that is taking accountability for the whole system, and that has to change.
And I personally have spoken to, probably over the last year, a dozen doctors and nurses, at least privately, and I have not spoken to a single healthcare practitioner that is in a good place. And I think they are all echoing exactly what you've been saying here today. So thank you so much for taking the time to come on today. I really appreciate your input. And hopefully, as it continues to change, it comes full circle at some point and doesn't cost too many people their lives.
Yeah, I hope the same. I hope we used to do a lot better and we can do a lot better. So we have to get coordinated and start listening to the experts again.
Thank you very much, Dr. Parks.
Thanks.
This is a politically centered podcast.